Thank you. Thank you again for the opportunity to speak. I'll try to get through this quickly. Just really, when I was, first off, no disclosures. When I was asked to talk, my first question was, what exactly do you want me to focus on? And the real question is, why should surgeons even care about this, right? We are a small percentage of the opioid prescribing when you think about what people's focus have been. We have acute pain that's different from chronic pain, and when we cause pain, but then we treat it. And then we're using evidence-based approaches to make sure those changes are occurring, and we've made changes in our practice. So why should any of us care about this and let the world around us do what they want to do? And then you take things like this. This was on the front page of CNN.com in March of this year. And so remember that while we all have the knowledge and the basis and the medical background, the majority of the public does not. And the majority of our legislators and regulators come from that public with that little knowledge. So you see something like this and you see a graph about how you give doctors money and they give you more opioids, and now we have an epidemic and people are dying. It's a very short line for people to get very upset and respond. And when the public gets upset, the legislators' response is to knee-jerk and calm down the public, so they're going to do things and get involved. So it's important that, realize we have to educate on that issue. If you want to go to the background, you heard a little bit about it. One thing is, yes, the Joint Commission released the pain as the fifth vital sign in 2001, but we want to forget is the fact that it actually came from the American Pain Society first. So it actually came from physicians about this pain as the fifth vital sign, which led to the regulations. Couple that with, as that came out, patients started to expect that their pain would be zero, that they would be pain-free, because we have medication for that. Then you throw on top of it, patient satisfaction scores were becoming combined with reimbursement, and so you want to make everyone happy. The consumer is always right phenomenon occurs. So people are prescribing more pain medication because if you don't, and your patients have pain, they give you a lower score, you could potentially have a lower reimbursement. So this came to about 20% of patients who are then seeing physicians and other practitioners who are receiving an opioid prescription. If you talk about sheer numbers, in 2012, healthcare practitioners wrote 259 million prescriptions for opioid pains. So it's enough pain medications to give a bottle of opioids to every adult in the United States of America. It's a significant number, and numbers and things like that come up, and legislators see that, and so they want to react. And when you talk about legislators and what they want to do, they want to find a solution, show they've done a solution, but that requires minimal work on their part and hopefully minimal cost. So a lot of times you go for the low-hanging fruit, which in this case is prescribing habits. So in 2016, the CDC started to respond and put out recommendations. They started with chronic pain. They carved out some bits of it. But again, legislators see that a government body or some known respected entity is starting to make comments on it. They're going to reflect off that. And actually, the CDC has expanded and has an acute pain also as well. Their recommendations are 3-day limits, actually, for opioids if you go online and look. So you've got the CDC putting out this information. Our legislators look at that and go, all right, now I know what I need to do. I'm going to go after that. So starting in 2016, all these states started to put bills in regarding prescribing. You had 30 states putting in at least 130 bills just focused on opioid prescribing. And by the end of last year, 24 of them have enacted legislation that either have some restrictions or guidance or requirements to opioid prescribing. That number is actually higher. In my state, it just passed in January. And then you also remember the governors have executive order capability, right? They don't need to wait for their state representatives to do something. They can do them themselves. If you look, and this is a little old, this is from the end of last year, this just gives you an idea of the range of what's out there regarding laws depending on what state you're in. Nevada has a combination statutory limit and limit of morphine equivalents. Then you've got some that have none. And like I said, my state's on there now, so it should be colored, and it ranges on how long you can do it. And this, again, this is the initial prescription, a limit to how much you can prescribe, and a patient has to come back then and gets it refilled. And these are in opioid-naive patients, adult and pediatric usually. So when you categorize what the states are doing, you can break it down to 6 big categories. They go after these prescription drug monitoring programs. Most states have these. It's some way to help monitor to make sure not too many prescriptions are being occurring. Some are good, some are horrible. I live in a state where it's pretty horrible, but it's getting better. There's the naloxone kind of criteria, which is, again, increasing access to naloxone to help prevent overdoses. You've got the prescribing guidelines or limits, like I mentioned, training or education. These pain clinics are going after, and then the other, which is everything else that goes in there, like Good Samaritan laws, that if you were someone who was addicted on drugs and someone that you know was overdosing, you could bring them somewhere and not worry about being arrested for drug use because you're trying to help save someone's life. and you look at how many bills that have occurred in the last few years, just looking at it, we're talking over 1,300 bills throughout the country hitting some level of this. So this is obviously on everyone's minds, and they're feverishly going after it. Congress doesn't want to be left out because it's Congress, so they have numerous bills as well. They've passed things in the past looking at opioids, but there are currently around 23, 24 bills in Congress between the House and the Senate looking at different aspects of things, including mandates for CME, mandates for prescribing limits, some opioid addiction, fortunately. But again, looking at PDMPs, they're really kind of hitting everything. And so if you want to look at the PDMPs, most of the states actually have that already in place, some form. For some reason, California and Florida don't want to share, so their databases are their own. And it looks like Missouri doesn't do anything, but actually St. Louis County has 79% of the population, and they have a PDMP. So Missouri technically does, since the majority of their population is in St. Louis County. But every state has something like this. So finally, Congress did do something. This is known as the DoNothing Congress, I should say. But they passed a budget. They all agreed, and they put $3.3 billion toward the opioid crisis, which sounds pretty good, right? They put towards abuse and mental health. They gave $500 million to the NIH, $350 million to the CDC. They gave $415 million for rural areas, $100 million for kids, an additional and I don't know why 299.5, just we're rounded to say 300 million to the Department of Justice, another $500 million to the VA, another 94 to the FDA. So great, they're giving all this money on top of what they passed last year in the 21st Century Cures Act. That's $3.8 billion. That sounds awesome. That's a lot of money. Well, remember, Congress deals in billions and trillions. And let me put this in perspective. When you look at, $3.8 billion for the opioids, for the 2018 fiscal year for the HIV epidemic, both nationally and global, they put $32 billion towards it. So if you're looking at it, Congress is kind of doing something, but have they really put the effort in to really address the problem when you're looking at a 10-time disparity between opioid, which is supposed to be our current epidemic, and the HIV crisis? So what are we supposed to do? This is all happening around us. Remember, legislators can pass laws that directly affect your ability to practice. They like doing it. They do it if they have to. So you can walk away from medicine. I personally don't really want to do that. I spent my 20s and early 30s training to get to this. I kind of put some effort into it. I like to do my job. You can stop prescribing pain meds, which is a nice thing that we try to do, and we have lots of pathways, but to be 100% opioid-free all the time is a high bar at the moment and really not realistic with some of our patients, especially the chronic pain patients. So we really need to address the problem, and you do that both inside the hospital, and really what I'm here for to talk about is the advocacy part, right? I'm one of your advocacy guys. I go lobby Congress. These are the things that we can do. So practice changes briefly. SAGES has this new opioid task force to provide guidance and understanding from different ways to address pain. We have our ERAS pathways that are already online, that are becoming popular. You reset the patient expectations, make sure they realize, I let them know they're going to have pain afterwards, and that's normal. And then you want to use evidence to guide our practice, which is what we do. But when it comes to outside the hospital, what can we do? What about the bigger picture? We need to lead not just inside the hospital, but also with our legislators and help educate them and show them what we're doing and why what they can do can affect our ability, and let us actually dictate, not them. We need to become more knowledgeable and really give the education, advocacy, and support to really show the differences, and then educate those making the rules so they know what works and what doesn't, because we're on the ground level. So a brief example, I'm going to give you my state. This is my governor, Governor Doug Ducey. Before he was governor, he was CEO of Cold Stone Creamery. So the reason that's important is that for the last couple of years, the only thing my governor cares about healthcare is opioids. Why being the head of an ice cream company makes you an expert on opioids, I don't know, but that's all he cared about. That's all he ever talked about. And he believed that physicians were the cause. The Arizona Department of Health puts this nice number up, and this is what you deal when you deal with politics. This is not really helpful data. Our PDMP stinks, I said that. They can't tease things out. So all they do is put up numbers of how many people died from opioids, and they're really encompassing all of us, not just the recreational use, but from pain prescriptions as well. And they put these statistics up where you could die, and people are freaking out, and they don't know what to do, and this is all over the web. And this is what's telling my fellow Arizonans what's going on. We have to combat this data, and this is what my governor's using to base his assumptions on what needs to be done. He believed we were the root of all evil, that he didn't care about the addiction stuff, or he wanted to change the prescription habits, so we had to deal with that. He started with an executive order. He affected 2 million people instantaneously by saying all of our state Medicaid, the access group, need to get 5-day initial prescriptions only for all the opioid naive patients. And then he told Access to go figure it out. So again, low-hanging fruit, look, I did something, other people will figure it out for me. Access fortunately realized that's a problem, had stakeholder meetings. I got to provide information regarding from the surgery side, and we carved out a 14-day exclusion for post-surgical patients, for burn patients, trauma patients, palliative care patients. They realized that it was far more complex, so we were able to enact change where it was more realistic, because who isn't going to see a post-op patient within 14 days? So it was fitting a paradigm that was meeting the standards the governor wanted, but we were able to give us some room to maintain our practice. Last year, he just declared it was a public emergency, which changed everything and put everything into overdrive. The Arizona Department of Health had these prescriber guidelines they had to rewrite. Again, I got asked to be on that commission, fortunately, through my work with the Arizona Medical Association, and provided surgical background. They had no surgical appendix. Well, they do now. Now, I didn't write new ones. I'm not that smart. As any good writer, I steal from other people. The Michigan database, OPEN, the Opioid Prescribing Network, had some great information other states did, and we used that, and now there's a surgical appendix, so we're not being roped in with everything else for chronic pain. And finally, we had legislation passed this year. The governor, again, came out with his 5-day, forget it, no, that's gonna happen. We met with him through the Arizona Medical Association, and again, we were able to carve out those surgical expectations outside of the law, which was passed unanimously, bipartisan, and it's actually going into effect later this year. So we were able to have direct influence through our lobbying efforts to change the law. We got addiction money put in, got other issues put in, but I'm happy to say that I can still practice and not have to change my habits because my governor, who ran ice cream, wants to fix the opioid problem. So what you can do is you can contact your state representative, educate them, educate yourself, educate them. They make the laws, you can help influence and give them information. Do the same thing on the federal side. When you see an issue, speak up. So really, in the end, I want to remind everyone that we are patient advocates, not just inside the hospital, but out. Our responsibility is to stop those who make the decisions from making bad decisions. We know better, so we need to educate, like we educate ourselves, we need to educate them. We need to lead by example and not react, so we need to be proactive with these things. Thank you very much.